Bill Weeks, who is at the late part of the stay in France, because he was 6 months here in Aix-Marseille University, hosted at IMERA. The stay ended in July, if I'm not wrong. And, so it's time to have the last time possible to have the intervention of Bill about geographic variation in hospitalization in France, which is the main topic he deal with this last month.
So thanks a lot for having me, and thanks to Fulbright and Dartmouth and IMERA and AMSE for hosting me here for 6 months. It's been a really fun 6 months. My 16-year-old son was here and went to school and became fluent, and I did not, so this entire thing will be in English. But I'll give you a background about geographic variation, and I know this is an infectious disease specialty group, and so we're going to be able to look at some geographic variation. We did some quick analyses to look at that, and particularly in the PACA region. So the geographic variation really looks at comparisons of costs and utilization of healthcare delivery in different geographic settings and within a country generally. So you can use a smaller region within a country, but usually the analysis is in a country, and you look at how much it varies, how much variation there is, just by virtue of living in a different place. There's a saying that we've come up with at Dartmouth that geography is destiny. So what we found repeatedly in the US is that what influences your healthcare utilization has more to do with where you live than with what kind of diseases you might have or how sick you are. And so we'll explore a little bit of that here and see how it applies to France. In the US, as I said, there's this has been studied. This is Jack Winberg, who kind of really started studying this in a paper that was published in Science, which you all know is a really, really top-notch journal in general. It's not specifically a medical journal. And the story about how this got published in 1973 is that he had tried to publish it in about 10 other journals. So the students among you, the researchers who get frustrated, he tried this in 10 other journals, all categorically rejected. And he says, what the hell, I'll send it to Science, and Science takes it, and it becomes this kind of foundational research paper for a whole field. But it was published in 1973, so what is that, 43 years ago now. And just to give you context, you guys, none of you were born at that time, it looks like. Very few of you were born at that time. But at the time, for those of us who were born, they were looking at the US, they were analyzing Watergate. So this is President Nixon, this is an eternity ago. So this has been studied for a really long time in the US. And Jack, who was living in Vermont at the time, this is Vermont, and Bernie Sanders, who you all probably all know, lives right up there in the northwest corner of Vermont. In Vermont, Jack was living, and he is an epidemiologist, and he just wanted to see, he just wondered kind of how things differed even within this teeny tiny little state. This state, the entire state has 300,000 people. It's the, I think, the second least populous state in all of the United States. So, and it's about 90% white. It's very homogeneous, and you would think that you would just find consistency of use. It's a small state, small population, very homogeneous. It should be used, similar use. So what he did is he looked at different, he called them hospital service areas, which are these darker flat areas, and these are U.S. counties. And so he looked at those, and he decided just to measure some measures of how much things cost per person and how often people were admitted to the hospital for different things per person. And he did that, and he found really widespread variation. It might be tough to see here, but if you looked at utilization of hospitals, there was twofold variation. Beds, the number of beds per capita was 2- to 3-fold variation. Number of physicians per capita was 2-fold variation. And spending per person varied by 2- to 3-fold, depending on what you look at. And then when he looked at actually more specifically at what kind of procedures people got, he found huge variations. It's a teeny tiny little state, up to 12-fold different rates of utilization for kids getting tonsillectomy. And he tells a story in his book that he lived in a town that bordered another town. His house, actually, the property that he lived on was in both towns. And he chose to build his house in one town, and in that town they used one kind of healthcare service. In the other town they would have used a different one. And he had 4 kids, and by virtue of living on one side of his property, he thinks that 2 of his kids did not get tonsillectomies. Because where he lived, 1 out of 4 kids got tonsillectomies, and then the next town over, 100 yards over, 3 out of 4 kids got tonsillectomies. So he really wondered about this is a strange thing. And he came up with an incredibly insightful thing, because at the time, people were looking a little bit at utilization, and the kind of the common response to seeing utilization was, wherever there's variation, the highest is the best, right? We should always try to do more. And all of these people are getting ripped off, they're not getting enough, because these people are getting more. But he said that he interpreted this as saying there's a lot of uncertainty in the practice of medicine today. That it's not clear exactly what to do. And he also says that given how much these varied, that the possibility of having too much actually harming you, because exposure to medical adventures can cost money, and it can cost lives, right? People who die, people have bad outcomes. So the possibility of too much might be as bad as the possibility of too little, which was kind of revolutionary at the time. Because again, the idea before was just do more, always do more. So the idea is when you see this variation, you got to think about why is there variation, and there's kind of warranted and there's unwarranted. And warranted might be if people really have different healthcare needs and the differences in use are justified, then that makes sense. Or maybe even if they really want more of something. If your population in this area wants more knee replacements in this area, then give them to them if you can afford it. Why not? Why not make people happy and everyone's happiness improves? Unwarranted variation is more like just the style in which physicians practice. So if I just prefer to do something and Bruno prefers to do something different, it doesn't make sense for our patient population that would be a good thing to do as far as using our medical resources. Also, if we just build more hospitals and the idea is then to fill them up, then that might influence utilization. That might be a bad thing because we might be providing unnecessary care. And then also there might be an idea of unequal access to care, and so where you have lower utilization, you might find that there's unfair, not as much access to care. People have difficulties getting into the healthcare system for whatever reason. And the idea is that in the studies, there's been about 40% of the variations have been warranted, but about 60% are considered to be unwarranted. And I'm just going to give you some examples from the U.S. These are Medicare Expenditures. Medicare is our insurance program for people who are 65 and older, so it's for an older population in 2012. And this shows kind of the variation in the cost per person. And it goes from $6,700 to $13,000, two-fold difference in the U.S. And here in Alaska, it's inexpensive. In Florida, it's really expensive. We spend twice as much money on a Floridian as we do on an Alaska. And you see these kind of patterns, you see individual patterns kind of come up. This is higher, the doctors are higher. But across this swath of the U.S., there's kind of more healthcare being consumed in comparison to the northwest up there, where there's just kind of less healthcare being consumed. And again, and this is when you correct for patient health status and for incomes and for things like that, it doesn't go away. It's mostly still there. The differences are still there. And you can look, you can look at it like this. You can see differences in costs. And each of these dots is one of the there are 306 hospital referral regions in the United States that we've studied for a number of years. And so there's huge variation. You can see it kind of concentrates, but you have to wonder why this variation. And if you look at a different aspect, that was just total cost, but let's just look at back surgery, which for those of you who are in the medical field, back surgery is really kind of an uncertain thing. You don't know. It's really unclear when to use it, and it's really unclear how effective it is. The only thing that's clear about it in the U.S. is it's a really expensive. It's a really expensive procedure, and people who do a lot of them become quite wealthy. So if we look at per capita back surgery rates, we see a little different pattern. Before we saw this really intense pattern here, but now where it was actually lighter before, lower cost, there's a high utilization of this particular thing. So you can't just look at one metric is the idea. You need to kind of balance things and say, what if, even if we're up here and we're saying, oh, we're low cost, we don't have to worry about it, we still might be worried about our back surgery rates because they're very different. And Honolulu and Casper, Wyoming, I consulted there, they were worried, they were the highest in the nation for years and years. And we went there and we found it's a very small community. It's not the horse, actually. One more thing. We thought it was the rodeo. That's what we thought, it's the rodeo. And that's what they claim. We went there. It's 40,000 people. Most of them are not cowboys, actually. Most of them are not cowboys, not in the rodeo. But what they have is they had 3 different neurosurgical groups. And what they told us is, if you just kind of get up and you just put your hand like this, within an hour you're in an MRI. And because they have 6 MRIs for 40,000 people. And you're in an MRI and you get surgery like that. And that's the reason. So it's a supplier-induced thing, probably more than a health status. But you see low use of it's kind of a different cross-country pattern here. And 6-fold variation in use. So it's really different. It's not explained by different healthcare needs and so forth. And like I said, yeah, Anchorage and Miami, in fact, they flip, right? Anchorage is high and Miami is low here. Before it was the other way around. So you need to look at this kind of multi-dimensionally. But one question might be, so if Casper is high rates, and if we're spending more in Florida, maybe that's okay, right? Because maybe if more is better, which is fundamental to the actual the belief that we should just be doing more. If more is better, then that would be a good use of scarce economic resources, right? Because we'd be making people healthier by investing more money, by doing more with them, and on them, and by make them healthy. So Elliot Fisher looked at 3 different categories of healthcare services. There's what we call effective care, and these are things like beta blockers after a heart attack. And this is good. You need this, right? If you have a heart attack, you ought to be on a beta blocker unless you have a contraindication. It's proper care. And in the US, about half the people, maybe now 60% of the people actually get effective care. Something we've known has worked since the 80s, and about 60% get it. There's preference-sensitive care where you've got different treatment options for a condition, and people might just prefer to have one treatment option over another. So if I have knee pain that's kind of bothering me, I can go kind of a medical watch and wait approach and take medications and do physical therapy and things like that and try to get better, or I can go the approach of a surgical intervention. And the belief here, what we think, is that people should get what they want when there is preference-sensitive care. But frequently what you find is if you go to an orthopedic surgeon and you've got knee pain, you're going to get a knee replacement. If you go to your internist or general practitioner, you're going to get the medical care. And so there's a difference, so that should not drive care, but it kind of seems to. And then there's this other idea of supply-sensitive care where you have more beds, where you have more physicians, you end up having more care. Just because the physicians have to keep their books filled, the hospitals have very high fixed costs, so the only way they can run functionally is to keep their beds filled, and that's how things have to work. But when we look at these 3 different categories, the key thing is what does more buy? Which of these does more buy? Because if it buys more effective care, great. If it buys more supply-sensitive care, not so good, right? So this guy, Elliot Fisher, looked at this. And here, just to give you an idea, this is the ratio of the rate in the highest spending region to the lowest spending region. So if there's a bigger multiplier, there's a bigger difference in the rates. This is 1, so this is equivalence of rates in high and low regions. And you look at these different categories of care. So if we look at effective care, what would we want here, right? In effective care, we want the rates in the high spending region to be way over there. We'd want to be buying a lot of effective care with the more dollars that we spend. So of course we see that. No, we don't see that at all, right? We see, in fact, if anything, a little bit less effective care in the high spending regions. So maybe there's preference-sensitive care. Maybe you get more of the stuff you want if you are in a high spending region. Same story, you really don't. It's a wash there, not a real difference. So what is it that you get for more dollars, you get a lot more stuff. You get a lot more tests done, you get a lot more visits, you get more consultations, there are more people involved in your care, and that in itself, having more physicians and providers involved in your care might in itself be kind of a bad thing, because there's more complexity, there's more opportunities for screwing stuff up, there's more opportunities for me prescribing one medicine and Bruno prescribing a different one, that they're the wrong medicine, there's a drug-drug interaction. So this is kind of really, this is bad in two fashions. You don't get anything more really that you want or that if you need, but you get this other stuff. But even then, maybe if you've got good outcomes from this, right? If you've got better outcomes with all these visits, maybe that would be worth it, right? So here's the same kind of graphic, and we're looking at risk of mortality for hip fracture. Now we're looking at different quintiles, and we're comparing the lowest cost group of hospital referral regions to the highest cost. And what we would hope is that as mortality, as expenditures go up, mortality would drop, right? That's what we would hope. That would mean good investment. So with hip fracture, it doesn't. In fact, it goes the other way, and you find out there's this higher mortality in the high spending regions. So how about colorectal cancer? We get the same story. How about myocardial infarction? We get a similar story, right? So what we're finding is you get more stuff, but the stuff you get is kind of not maybe effective, and maybe it's for one of the reasons that I mentioned is just there's more complexity in drug-drug interactions and less coordination of care when more people are involved. So there's been 40 years of research in the US that can kind of be summarized as that there's a lot of variation in costs and in use, but it's not, there have been other studies I didn't show you that show it's the improved or the higher costs are not associated with patient satisfaction. They actually find in high cost regions that they're less satisfied because the care is so complex, and it's actually tougher to get in to see a doctor in high utilization areas because they are so busy kind of competing with one another and filling their books. There's much worse care coordination, there's worse quality care, and there's not better outcomes. And we found that, I did a study that was published earlier this year that found that unfortunately these patterns aren't changing. This has been published and publicly available for about 15 years, and the patterns are the same. The high cost regions 10 or 12 years ago are still the high cost regions, the low ones are still the low cost, nothing is much changing. But maybe in France, right, there's hope, because you all have much more of a centralized government system when it comes to regulating the supply of these resources, and maybe in determining what people actually get and determining what the care pathways might be. So we looked at geographic variation in France, and we started to look back in the first, actually, Emile Durkheim was this father of sociology who was the kind of the first true person who studied geographic variation. And he studied it in France, and he looked at suicide, and I'm a psychiatrist, and so I thought this was interesting. And he found that there were really concentrated areas, the darker areas are higher areas of suicide. We found there were concentrated areas of high suicide rates, but also of alcoholic kind of craziness, right? And people up there, they look at that, and this is from, I can't remember what year it is, so 150 years ago, and right, and it's the same thing, right? One would expect this. No one's surprised at it, say. And also consumption of alcohol, right? You see this pattern, these national patterns. But since then, so Emile Durkheim did this, and he did more of his sociological kind of experiment to understand these new methodologies. But there hasn't been all that much geographic variation study in France since then. So what I've been working with Bruno and Alain and Marie on and others is to look at geographic variation in a variety of different, for a variety of different reasons in France. And the easiest thing to do when you get very complex, or you start kind of when it's easy, and the easiest thing to do that we found was to use, to look at hospital utilization, hospital discharges, because Marie was able to find us this fabulous discharge data set, and we were able to analyze it, and we thought about how to analyze that. So we looked at a couple of different things. We looked at elective surgical procedures for these preference-sensitive conditions. Again, these are procedures that have medical alternatives, and the problem with this is there's opportunities for overuse and underuse, right? Some people might get too much, some people might get too little. And the other area was in ambulatory care sensitive conditions, where the ambulatory care sensitive conditions are hospitalizations that probably could have been avoided if there had been better outpatient care before and more coordinated outpatient care. So this is frequently an indicator of a failure of a primary care system and a need for more primary care physicians or more primary care access. So we looked at these data sets that Marie got for us, and we looked at the department level. In the US, we looked at a hospital referral region level. Here we looked at department level. And you correct for, obviously, the underlying population to generate age, sex adjusted rates of admission, just using the same methods that we use in the US to do this. So we did that for 96 departments, looking at mainland France and Corsica. And then we looked at different measures of geographic variation. And we used some spatial regression techniques that take into account that proximate areas might influence one another. So I'll show you some results for elective surgical care for these preference-sensitive conditions. Again, these are multiple treatment options with similar outcomes, things like prostate enlargement, that you can get a TURP or you can get watchful waiting. The joint replacement I already talked about. Angina, you can get medications or you can get percutaneous coronary intervention or CABG. And ideally, patient choice should drive this, but research in the US has figured that other stuff drives this. And what we really found here is that there's a lot of geographic variation. We found some regional patterns. I took this out because I was going to talk some about the infectious disease stuff. But we found that generally in France, you've got some declining rates. There's been increased use of the public sector since you instituted this T2 system of reimbursement, which is more of a DRG-like mechanism. And we found decreasing variation. So it seems like France is kind of doing the right thing, actually. And things that we can't do in the US, where the geographic variation is identical and nothing's really changed, is actually kind of converging for, we studied, I think, 12 elective surgeries. For about 9 of them, it's converging. There's a convergence of rates and lower geographic variation when you look over about a 6-year period. But we were a little surprised we didn't find a relationship between median department level incomes or density of physicians or specialists or overall admission rates or beds, or even the proportion of for-profit hospitals. So we're not sure exactly why, but it looks like things are just kind of converging. When we looked at variation in admission for ambulatory care-sensitive conditions, we found we had to group them into different categories. And here's just an example of the categories we use: alcohol-related, vaccine-related, acute and chronic, and then others, just a catch-all. For chronic, you can see that the rates are much higher. This is the rates per 10,000 people. The rates are much higher for the chronics. They account for the majority of the costs and the bed day of care consumption for the other groups. But you can see as well that there's a slight increase in the alcohol-related, the vaccine-related. This means that had people gotten vaccines, they might have avoided the hospitalization. Alcohol-related is simply because if you got good outpatient treatment, you might have avoided the alcohol-related admission. And acute is more things like people have pneumonia, suddenly, again, things that might have been covered if they have urinary tract infections, upper respiratory tract infections. It might be prevented if they had better outpatient care. But in the big cost item, the chronic care is actually going down. And these, I should have said these dots, but these dots mean this is the high and the low rate within the 96 departments. So the line here is the median. This is 25th and 75th percentile. This is plus and minus 1 standard deviation. And these are the variation. But you can see, even though there's some convergence and things like that, here, it's about a 5-fold variation in the rates across France. And over there, it's maybe about a 2-fold variation. So it's not perfect, but you're getting there. When you look at how much resources that are consumed, you see there's a lot. There's about 700,000 bed days of care that are consumed by these avoidable admissions, potentially. And if you think of your policymaker, that those 7 million bed days of care could have provided a 250-bed hospital for each department in France. So it's a lot. So so when you think about investing in one thing or another, that's a lot of money. It's an expensive endeavor to have one 250-bed hospital in every single department in France versus providing better access to general practitioners some way. Some other findings were that we found there was a positive relationship with mortality rates. There was a negative relationship with per capita general practitioner supply, which suggests again that maybe an investment in more general practitioners might result in less of a need for these kinds of admissions. There's a positive. Sometimes we found that, for instance, with chronic and alcohol-related, if you there's a tendency just to admit more in certain parts of France. So some places just kind of admit more. It's a cultural thing probably. They just are more reliant on the hospital. And the regional patterns are pretty consistent over time. Here's just some specificity for you. You find that the chronic diseases are more of the northern part of France, as are vaccine preventable and alcohol related. So most of the problem is in northern France, and one of the issues that you see is things have not changed a lot, right? These are alcohol-related admissions in France in 2013. Here they were, here are the alcohol-related kind of admissions 150 years ago. Things haven't changed, and the patterns are not hugely different, which suggests, again, some kind of a cultural problem or perhaps an underlying geographic problem of the underlying population. So now, so that's kind of the work that we've done, and then just for fun, for this lecture, we used the same data set to consider variation in admissions for infectious diseases in France, just for 3 years, 2009, 11, and 13. And the way you categorize these things is you look at the ICD-9 code, or the ICD-10 code rather, that is associated with the admission, the primary reason for admission. We looked at A and B codes, which are those, and we did the same age-sex adjustment methodology. And you find that there's been a little bit of a change in rate, a little bit of a decrease over the 6-year period, downward from 4.2 to 4.0 per thousand, and a decrease in in one of the measures of geographic variation. So things are going down and becoming more consistent, and that's a good thing. And the overall admission rate is relatively low at 4 per thousand. This just shows that the variation is kind of slimming, right? There's less difference between the high and the low as you go forward, which is good. You do see some patterns of geographic variation. Again, the north has some concentration of the darker areas, which are the higher areas. But right here, in your own little backyard here, there's a fairly high concentration of this. Maybe, I imagine you guys know this already, right? That this is a fairly intense area for these kinds of admissions. There's some potential explanations that we thought about. Here's the infectious disease admission rate. It's there seems maybe to be some association with population density a little bit. It looks like it overlaps a little bit. Not so much with mortality rate, maybe a little bit with overall mortality, hospital admission rate, and not so much with population income or medical beds per capita. And when we actually look at it, the population density and income population density where there's more, you would have more admissions, right? Higher population density, more admissions for these kind of things. Income, where you have lower income, you have more admissions for infectious disease. And overall mortality was actually inversely, so we had lower mortality in the underlying overall population. You had a higher admission rate for these as well. Those were the significant ones. The others really weren't significant. And then looking here within the different departments that constitute PACA, you see a lot of differences in the 3 years examined over the 6-year period. And just show you, the red is the national rate is kind of decreasing over time, but you see there's some stability here. Provence has dropped considerably. Alpes-Maritimes has gone up, as has Var, right? So I don't know, I was going to open this up to you guys and see why has that happened. Any ideas? Has anything changed? Or do you look at this kind of thing, or would it be helpful? I would think you'd kind of go, wow, what's going on? Go hang out with the guys in Var for a couple of days and go hang out with these guys for a couple of days and say, what's different? What's happening? What's been different in the last couple of years that is accounting for this? It might be an interesting thing. But no, who knows? So in summary, we found there's a fair amount of variation, but it's declining over time. There's some changing patterns, particularly if you look at the departmental level within a high utilization area like this. And you actually, for elective surgeries, we actually found considerable international differences. For variations for ambulatory care sensitive conditions, we already kind of covered. And for you guys, we found some relationships to population density for infectious disease, population density, income, and mortality rate, and high rates in population in general, but really very different rates. I mean, you even look at this. This is within your own region, right? So Cluse is really pretty low, on the lower end of the spectrum. The spectrum nationally, and VAR is exceedingly high, and this is all within your kind of local region. There are limitations, of course, to any study that you do, and we have the data, so that any problems with this is all Marie's fault. She provides the wrong data. No, I'm kidding. It's just you can't always get the access to the right data, and we wish that we had more variables so we could look at things like, one thing we haven't been able to do is say, are these actually needed? Do we need these admissions, or do we really not? If you use a different area of geographic determination, that you might come up with somewhat different results. And again, we don't know if these were warranted or not, these admissions. But particularly in the context where you're facing some healthcare deficits in France going forward, right? You've had some healthcare deficits, the costs of care are kind of going up, and your ministers are worried about the costs going out of control and more like the US. Maybe this should be monitored. Maybe that would be a useful thing to go to VAR and go to the other place and say, why is this so different? Why are your patterns so different? You're only, you're within the same region. Why is that different? And we should think that ambulatory care sensitive conditions should be a priority because they consume so many resources, and there are alternative ways that are effective to prevent those healthcare, that expensive way of caring for people, to prevent that from happening. And the idea is that, again, just like maybe with VAR and the other region here, you might look nationally and try to partner places with low utilization and high utilization so that they could learn from one another and learn new patterns and try to even more rapidly accelerate that convergence to some kind of a more consistent and thoughtful and not only policy-driven but care-driven rate of consumption. So that's all I have. I want to thank Alain and Marie as well for the older stuff that we provided, and Zainab Orr and Gregoire Mercier for the new stuff that we're showing here. So thanks, and I would welcome any questions if you have some.
Well, it's very typical of the fact that it doesn't move so much in the USA. It's very typical of the pathway dependence. You know the theory, of course. The pathway dependency. You know the theory, of course. That's in fact, when there is a pathway, it's very hard to change it. Right. To change it. So you can get that for 1 century without any other explanation. Yeah. But it was there 1 century ago, and we're doing the same, much more, pretty much more. It's a general rule, which is named the pathway dependency.
Yeah. And I mean, just be specific about it. I think we call it, practice pattern culture. That the way, both the way that the physicians provide the care and the expectations of the population interact to cause this consistency. But again, you're seeing the difference is kind of the thing. If that were a universal truth, right, you would just think that France would be the same as well, but it's not. It's actually converging. There's decreases. In the US, we're seeing increases in rates and just the same amount of geographic variation, just no changes. Here, you're seeing actually convergence over a relatively short time period, where they did make some policy interventions that include the DRG and the T2 thing, as well as some implementation of minimum minimum threshold standards for several different surgeries around cancer treatment and heart treatment. So the policymakers in France actually are using some tools that one would think would cause some convergence and cause, you know, an overcome of that natural tendency, because you've been inflicted new rules, right, that force patterns to change in the right way in this case too. One of the problems always it might.
Well, one of the things is that one of the things that is very special in France is that the people organizing the hospitalization so far are moving. This is one of the very few things that are organized by the central states, is that they're moving. So you don't have a real culture of the people organizing the care, which means that you cannot get the pathway, because you know, here, for example, the current director comes from Amiens, and the boss of the IRS comes from Strasbourg, and so on. So you cannot keep the pathway just because people are moving so quickly that you can't get the pathway. And it's the same now for the doctors. For example, in this area, 50% of the doctors have not get their diploma in France.
In France, well,
and only 25% of the doctors coming here have done their specialty in Marseille. So 20%, 25% come from all parts of France, and 50% from all over the world.
Yeah.
So there is no more pathway.
That's interesting.
This is what you see here. There is no pathway.
Yes, you know, in the U.S., we've got studies where we've looked at physicians who move from a high-intensity region to a low-intensity region, and vice versa. And what they do is they adapt to the region. So when they go from high intensity to low, they do less stuff. Not all the way less, but still less than they did before, and vice versa when they go the other way. And that would be fascinating to see what the doctors do here, or to track the administrator. That would be really interesting to see if administrative move, a powerful administrator moving from a low utilization to a high utilization, if utilization drops faster than expected, would be a really interesting study. Because that would be another really effective, if it did work, what a great policy intervention, right? Just pick say, hey, you're moving, you know, you're moving.
Albert, some other comments, some remark?
Merci.
Okay. Thank you.